Hey, Gestalt Education Nation. New sponsor alert. Today, we're excited to announce Dynamic Disc Designs and Jerome Fryer. We have an awesome discount code for you. Just use the code Gestalt to get a little bit of money off on the Dynamic Disc Designs. They're the most realistic anatomical discs that we've ever seen. If you caught our episode with Dr. Stuart McGill, you saw an entire shelf full of them. Everything from cavitation instruction to disc dysfunction to SI joint dysfunction, all sorts of amazing
joint
stuff.
movement,
Yes,
vertebral movement.
Absolutely. So go to Dynamic Disc Designs, use the code Gestalt. As always, you can use the code Gestalt on Core 360 belt to get a little discount on the belts there. We love to use that for biofeedback for teaching respiration, intra-abdominal pressure, and how the abdominal wall should be working during function. And then the last one, use the code Gestalt Education 10. Those will all be in the description in the podcast. Gestalt Education 10 at humanlocomotion.com to get off some money off of all of his awesome gadgets and tools and rehab materials. What's your favorite, Brett?
He's got a trunk full, but I think, integrating the Toe Pro in, I think, has been a game changer for us here at the office. So I think that would be my pick.
Beautiful. All right, guys, don't forget, use the code Gestalt, Gestalt Education 10. Visit the show notes and you'll be hooked up. Thanks. Enjoy the episode. All right, everyone, welcome to another episode of the Gestalt Education Show. Today, this is a special day for me because this is my first time ever at the legendary Model Hospital here in Prague, Czech Republic. And so this has been a journey that I've been on since my first DNS course ever, Brett, which was with you and then Elena in Kansas City. And over the last 7 years, I've gotten to meet awesome people, one being who we're sitting down with today, which is Marcela Safarova. So Marcela, you are a physiotherapist, you're a lecturer, you teach for DNS, international instructor. How I know you is your expertise with pediatrics, scoliosis, pelvic floor, like all these other amazing things. So today we want to kind of, me personally, I want to dive into some of those things. We're going to talk a little bit about reflex locomotion. You're also an instructor for the Voita Institute. And so can you maybe just quickly kind of summarize how you found DNS, how you found Pavel, like what got you to this point here?
Okay, so first of all, welcome here. I'm happy to meet you here.
Yeah.
Which is a really big, even for you. Well, actually, it's a long story, I have to say, and it is a funny story at the beginning because when I finished university, so I was trying to find a job where to work, and I said, well, not Moto, it's such a top for me, so I cannot even ask there because, I was a bit like afraid to go there. And because Michal Truc, he was my schoolmate, and he said, oh, don't worry, come here and meet us, And it was a really first step. And when I met Pavel, after the school, where my really big guru was Professor Levitt at the first time. And when I have met Pavel and we have been working together, I said, oh my goodness, it's something different in a good way. It's a more than this would have been taught at university, It was like overlapping and it was really triggering our interest and it was really great. And we starting to, I've been really honored to be part of the team to help him with the courses, and it was a really early, or many years before the DNS was developed as a DNS. Sure. And it was really nice journey, and I'm really happy for that.
Yeah. It has been a journey for you, I'm sure.
Oh, yeah.
I think. Most people know with Marcela, I truly believe she's the best in the world at treating pediatric patients. Can you tell us about your experience with the Voita Institute, how that's led to DNS and that whole story?
Yeah, so I think what is really important to know that, and as Pavel is mentioning in his lectures, that because he met Professor Voita and he was influenced by Professor Voita and many big names from Prague School. So, and he put all these informations together and developed his own approach is a really foundation for the DNS concept. And DNS, because it's based on the knowledge from the developmental kinesiology, and in Voita approach or Voita method is the development also really big part of the educational process or the topics. So it's a really working easily and nicely together. And I think that those therapists that are working with the both concept are really happy too, because one is enriching the other one, and it's really great.
Yeah, it's Gestalt. The multiple together is great.
Exactly.
Mm-hmm. Well, when we're sitting here, you have one of the original posters behind us about these postural reactions and postural positions that really influence your assessment when it comes to pediatrics. And so can you kind of talk us through maybe how that, the story I always tell is it doesn't matter if you're born in Prague, if you're born in Troy, Missouri, or Australia, like you hit these same developmental milestones, and these different reactions are there and hopefully gone at certain milestones, but maybe how that influences your assessment when it comes to pediatric patients.
You know what? More I know that I have to know more. As it happens. And what is really great that Professor Voita, he studied Arnold Gestalt research, and he because the Gestalt, he described all these milestones, what the child is doing when exactly, and Voita add all these kinesiology content, so these muscle analysis, how it works. And what Pavel add was also look at this from the biomechanical point of view. So this is a closed kinematic chain, open, what is the rotation, this, that. And it's really, really logical and really nice stuff. And to know these evaluation according to Voita, it's helping us to see really important details, and these details, when we collecting, we know what the child can has a problem, for example. So I think it's a really amazing tool to assess the quality of the movement behavior of this particular child. In these days, I have to really say that the Voita, it was one of the neuromaturational theory component, and now we are living in a time where it's also important what is the experience of the child. So it's not about the simple brain maturation itself. So the brain is old, 3 months, and then the child is supporting between the elbows and the symphysis. But also if the child has an experience. So those children, they are experienced by many positions and some triggering with the interesting toys, whatever, and the movements. So they have another movement pattern behavior. Then these are, for example, they have a movement deprivation because they are living in a without a proper family, So, and I think it's a simple meaning, but it's so important for us to know in a pediatric field, because what we are doing in a treatment, that we add some a proprioceptive information, which is important for this afferent setup, and this is kind of experience for the child, even artificial. So child normally cannot do, for example, the support. And when we are doing the support and offer the support during the treatment, we are send the information to the brain. Look at this, how the ideal support looks like. And with the many repetition, many proprioceptive information, we hope this information is a building up and create some a synapses, etc., and create some new possibilities to work. And in these days, what is a goal of the pediatric treatment is that we have to improve the posture, for example, and improve the child so far to help him to use his own movement strategies. So we are not doing, look at this, the child cannot move with the arm, so we are not doing passively the arm movement. But when we support the rotation of the spine, position of the chest, position of the pelvis, then the child easier can start to move with the arm, for example.
You always cite the research with from Prechtel and Voita that 30% of children may not be in the ideal development strategy. How important is it to be assessing our kids? Because in the Western part of the world, the United States, our pediatricians, we're not very good at, doing, these tests and things like that. Can you kind of explain why that's so important? And then if you are in that 30%, what is the strategy to help you?
Yeah. So these 30% of children can be, well, actually 70% are developing normally, let's say. And it's not only by Prague, by Voita, also from the many different evaluation, which is good, which is telling us the same number, more or less, which is great. And what is important that these 30%, which they have not ideal development, they are divided into 4 categories. According to severity. So the number 1 is not so severe, so very mild, severe, very severe. And these first 2 categories, according to assessment of the posterior reactions and reflexes, are not indicated to the treatment. But we ask the parents to come, or caregivers come to us to visit us, and we will check if during the time, like a spontaneous development, the child is developing more towards the correct situations or maybe incorrect. So we see if it's improving or not. If it's improving, so they have some advices with the handling, whatever. And if something is getting worse, we see more tension somewhere, or more fisting, or the child is not moving according to the age. So the child is we invite the child a little bit earlier, and it's getting worse as well, or we see a more pathological reflexes, for example, so it's indicated to the treatment.
And then how often do you like to check up on the...
So the child from the first group is invited after 6 weeks, from the second group after the 4 weeks. So it means that the child which is a little bit worse, it's a shorter time for the regular visit.
You're talking birth would be the first time you check up on them, or soon after?
No. So it's not here like this, that every child is generally checked up by the obstetric clinics or the pediatricians, definitely. But sometimes the parents are coming and saying, so maybe it's not such a good because he's doing this, or he is not turning the head at all towards the other side, or I can see flat skull or something. Sometimes these children are sent by pediatricians. Because the pediatricians, they do not really cover all these details in a movement, behavior. They have a lot of stuff cover. But this is also the option from which, specialists, the children are coming. And when we have a child with a third category, so which is a severe, and a 4 is a very severe, so these children are immediately indicated, and it's absolutely clear that must be treated.
What do you think the reason is for getting in that 30%? Genetics, and what are some of the factors that lead to that?
Well, this is a really good question, and I'm not sure if I have an answer.
Yeah.
So why it is 30%?
Well, not what,
and what is behind that?
Yeah, exactly.
So maybe this is it can be like a genes or something. It can be something which is happening during the development in utero as well. It can be like an environmental influence. So I think that we cannot point exactly this is the problem. If we knew it, so I think let's ask for the Nobel Prize.
Do you think though there's a genetic predisposition? Do you notice with your families that if one child is in a 30%, that other children in that family are also going to fall in that 30%? Or
I don't think so.
I
don't think so. I think what can be genetically coded is, for example, some when in a family is typical, for example, patellar dysplasia, for example, or this dysplastic situation on the somewhere on the body. So it can be inherited in the family. Scoliosis is a typical problem. So when one of the parent has a scoliosis or in the family, so the children are really risky. And if we have one child, so I have one case now. So the girl, she had a really big curve. And the younger sister, so a big curve means that she came when she's 42 degrees, according to Kolb. And the other one, so the younger sister, so she came with 16, 17 degrees. No big issue. So and the family, they made a decision to treat the scoliosis, the older one, conservatively, so no surgery. And I said, look at this, because we know, and she progressed till 70 degrees. So she has now 70 degrees. She's adult. She is, 22 years old now. And the younger one, I have not seen her for 2 years. They have some kind of like a problems in a family, divorce, whatever, complicated situation. And she did not use the brace at all. She did not exercise at all. Now she is a 50. And I said, when we have been at the beginning of the story, I said, look at this. So she is in a risky situation because we already know that the sister has this maybe gene combination, which is typical for the progressing scoliosis, which is already, by the way, shown or proved in a research that exists some gene combination, which is saying this is a typical for progression. So, and I hope so. In the last world meeting for the scoliosis, meeting, there was announced that already exists kind of like a genetic test from blood or saliva. So I do not remember exactly, which is already it's already available for the screening those patients which will be really progressing quickly. So which is like a new period of, like a screening time for the scoliosis when you already do simple tests and, look at this, you have a big risk in the family. So you have to really be in a brace early or, so doesn't matter that you have now like a 15 degrees. So let's start with a brace really early because you have this risk.
And not wait till it gets too far.
Exactly. That's
in medicine, I think sometimes we're so bad about like we are good at like saying, well, this is the dysfunction, but the treatment's not good. So can you talk about how important the treatment is for these 30% and what it's actually doing? Because one of the hallmarks of DNS is we change how the brain and the central nervous system is using or organizing all the muscles around our joints. So if we don't treat them, then we run the risk of the structure being...
Yeah. Well, you know what? It was a couple years ago. I have met one, not personally, but I have heard one speech, and it was about how it's important, for example, to talk to little babies. And this, when you are talking to the children, so the really frequently, and doesn't matter what you are talking about, if you are talking about the recipe or what. So the child,
arguing with your spouse,
and you can see the child is really reacting. It doesn't work with a tablet. It's very funny. But when you talk to the child and child can see the interest and you can see the eyes, etc., the brain architecture is different. Because you send there's some kind of like a afferent setup and the child reacting. And there was a research. It's a 30 million gap research. If you have not heard about it, it's really lovely. And it's a really measurable situation that when you compare the situation in the families which are talking to the small babies, the brain architecture of these babies are different. They have no big problems at schools. They are easier educated and they can reach the university level, academic level at all. That's beautiful. And those children, sometimes you have a mother and the mother is talking, you have a lovely toes here. And they said, I'm talking all the time. Then you have the other family or the other mother, and she's just saying, okay, new diaper, nothing, and then put the child in front of a TV and it's not work from the TV. So, and definitely these children, they have a problem to start to read really well at school. And the first years at school, you are learning read. And from the 4th grade, you are reading to be able to learn from your reading. And when you are not able to read properly, it's difficult for you to learn. Mm-hmm. And look at this, how it's really logical. And I see this like a parallel situation with our profession. When we offer the nice physiological proprioceptive input information, I'm pretty sure that the brain is able to organize it. And then the information which goes back to the muscles can really help to create also the nice shape what is Professor Klaus talking about all the time, which is really important for the development, for the maturation, skeletal maturation. So this is our job and this is our message, that when we are working with small children, we have to offer the best position ever in a different situation, and then let the child try his own movement strategy. And this is simple, our job.
And how long are your sessions when you're treating the children? And then, like, if you are in the 30% and you're actually doing treatment, how often are you seeing them? How long are the visits?
Okay, at the beginning, I have a between. I'm really happy that I have a between 45 and 60 minutes per child. At the beginning of the treatment, I have for example, 2 times session per week. And when I see that they are doing good job, so I can see them once a 10 days or 1 or 2 weeks. So, and depends on the particular problem. So, which can be, I don't know, the supporting function, or the child is not moving properly, crawling properly. So, depends on the particular problems. We adjust what we are doing and how often, how frequently, and simply saying so. More frequently we offer the right situation, so easier the brain create the synapses, how it looks like, and depends definitely. It's not only about this afferent, but also about the hardware, how the brain itself works, definitely. But we cannot say that it's only about the brain itself, how the brain matures, and that's enough. But also the experience that we pronounce some position. So I'm pretty sure that never ever the position which we are using for the treatment is not like for the child like a typical for the spontaneous like a situation, you know. But this is important because we stretch some structures and show the brain that it's possible to rotate whatever, you know. And I think it's a really when I say myself, look at this. This is so simple. This way of thinking. You can do whatever you want in a proper physiological like a situation, and then we are helping the child to create this like a optimal like setup or output.
What makes you so unique is because you're an instructor for the Voita Institute and DNS. So would you say that in these treatments, you're kind of doing a hybrid where you're combining some concepts of both?
Yeah. So, well, from my personal experience, and I guess it's not only from me, it's a really great combination to use the both concept, and the knowledge is really, really great to use from the both sides. What I think, and I'm telling all the time, when the child is indicated in the right time for the right diagnosis with the Voita, I do not know better, more effective treatment. Because we can do a lot of the DNS, but DNS is a more effective when the child can follow your instructions. Right. Mm-hmm. But sometimes you have to start a treatment really early. So in a really like a couple months, the child is a few months. The age of the child is like a few months, and we cannot say, can you create the right canister or maintain the intra-abdominal pressure. So it doesn't work. But we can use some positions and the loading in positions which provoke this activity. And we know that, for example, in a Voita treatment, the activity of the muscles depends on the right position, the loading in this position, and some like points for stimulation. And some of the patients are sensitive that even they are just in this position and they start to work. So they start to upright because it's a natural way of like a movement, like a locomotion movement forward, for example. So even those people, they are not educated with the Voita treatment. If they understand these principles, so they can really do a great job. Yeah, when they are using such a positions from the development.
And I know Pavel says his greatest influence was Voita, and I'm sure you'd say the same. What was it about Voita that was so mesmerizing and special for all of you guys? Like, what was he so good at? We always say, like, what was his gold medal? Like, what was his huge skill?
So brilliant observation. So I think brilliant observation of the children and see the details. And he really was great to connect the information. Okay, when I see this, okay, it maybe means this. And we said, oh my goodness, you know what? I have, it's many years ago, I was trying to read the Voita's book in German language. It was my German language was really poor, and I asked my father-in-law to help me with the translation, and so he rewrote it in Czech language, and I was so happy. And when I have read and it was a chapter about the history, how Voita developed and under which his the meanings and the influence and the ideas, it was like a detective story, you know. Sometimes I have a goose skin because oh my goodness, how he can say this when he see just this detail.
Amazing.
It was amazing. Yeah. And what is really good to say that he said, I cannot say that I was developed that. Because the Voita method or these meanings already exist many years and ages ago. I just was talking about this and said, work with that, you know? So, which is also cool. So what
do you think reflex locomotion's role is in like orthopedic medicine or just our everyday patients? Do you feel like we'd only need DNS for that, or do you still have a place for reflex locomotion in these other category of patients?
Well, as I said, the reflex locomotion is really amazing, especially for neurology patients, because you are really targeting quickly the software, you know. In orthopedic patients, it's also really good because you are under a reflex locomotion, you can address or activate these muscles which are not easily under voluntary control. So this is one point. When we are using the DNS position, we can do the same thing. So I can ask the patient with the orthopedic problem, go into this position, because I know that for this kind of movement, the person needs to have eccentric contraction of the glutes, which is his problems. And I'm not talking about that now you are training the glutes, you know, but I am saying support here, and touch me here, for example, or contact me here, or target here. And I know that I'm doing it to use it for improvement of the eccentric contraction. So it's a lot of similarities, and we are happy that we can explain it via the knowledge of the muscular analysis, which is coming from the reflex locomotion, for example.
Sorry to interrupt your episode, guys. I have to tell you about an important date to write down in your calendar, November 3rd through the 5th, the first annual Neurodynamics World Congress coming to you at Parker University in Dallas, Texas, November 3rd through the 5th. This is an amazing opportunity to see a true Gestalt weekend, meaning integration of multiple different people, multiple different techniques of the likes of Michael Leahy, Antonio Stecco, Brent Winchester talking about DNS, Annie O'Connor talking about pain classification mechanisms, David Seaming talking about the internal chemistry, Jeff Bove talking about the research around nerves, and of course Michael Shacklock talking about neurodynamics. This weekend at Parker University, November 3rd through the 5th is your opportunity to see not only lectures, but hands-on demonstrations and panel discussions at the end of every day to combine this all together to show how each of these different techniques is influencing the nervous system. This is an amazing opportunity to see all these people in one stage and one opportunity to have some fun with us in Gestalt education. So thanks for taking the time to listen to this episode, and we can't wait to see you at Parker University. It's November 3rd through the 5th. Registration open at gestaltedu.com/courses. See you there.
The pictures are so interesting. I feel like it's just amazing to see how he described these anatomical linkages and chains, but there's no mention of intra-abdominal pressure or diaphragm, anything like that. What, did he just not talk about it much, or just ran out of time to talk about it, or what do you think?
Well, it was funny because it was also the discussion between a Voita's group and a Pavel's, and the one guy, he said, well, it is so interesting. So we never talk about the diaphragm, and it is so important muscle. Oh my goodness. And also what he said, look at this, what the Pavel is saying. The Pavel is saying that we have a generator, which is a diaphragm, of some tension in our trunk, which is helping us to be like in standby position. It's not like a nothing here and then we do the action, but the diaphragm generate all the kind of like a tension, and it's so important because when even we are doing the like a reflex locomotion, whatever, so it is a kind of like a tension in the whole body, and the body is going into some locomotion vector movement. And nobody was really talking about the diaphragm and intra-abdominal pressure, which is like an automatical part of this movement. Without this,
because when you do reflex locomotion, you clearly see it. So it's kind of fascinating.
Yeah, maybe it was also about a little bit about the terminology, because they are not talking, for example, that it's creating the intra-abdominal pressure, but they are talking about this, that in this stuff, there's the changes of respiratory pattern, for example, and respiratory pattern apparently is a diaphragm.
And a lot of our listeners are probably still doing some reflex locomotion. How important do you think it is that these vectors are exactly anterior, caudal, ventral, like how the precision, do you feel like?
I think it's really important at the beginning when you start with this approach, because you have to start with some kind of like an idea. So you have a kind of like a reference point. When you are going from one point to, it's good to know that you have to like the direction is towards the shoulder, for example. And then when you are working with these points or with these vectors, you can definitely change it a little bit according to your experience, your skills, and according to reaction of the person, of the patient. So definitely. So not necessarily you have to be so precise, but also my arm has a different parameters than the other one, and you have to centrate the whole system. So which we are doing also in a DNS concept. So we are also talking about the position, how it looks like tripod or the obliques, but we have to adjust a little bit according to proportions of the patients. So we cannot say, look at this, you have to have a 120 degrees of AB reduction here because one has a 125 and one 119, so it's really, and this is the art. So those people, they have no really, it's difficult for them to have the skills to adjust the body into the centrated position. So they need this information, 120 dot, and they can measure the angle, and it doesn't work because the real patient later needs, for example, a little bit more or less. You know what I mean?
Oh, yeah. In DNS, we use like a lot of distraction or approximation when we're doing our treatment. Did Voita ever talk about that, or that's been more of a DNS concept?
Well, I think it's maybe, again, about the terminology. They maybe use a little bit different words, but they are doing basically the similar things because it's the same body all the time.
Right.
You can push.
That's the one break
pull.
we get. It's the same body.
Yeah, exactly. Yeah. So when we are talking about the flexion is all the time flexion, right? So sometimes we know that when we want to improve the support, for some patients it's better to pull to distraction, and it's a really facilitation, especially when you have a patient with a spastic arm, for example. Yeah? When you have a hypotonic child, you are doing more approximation, vice versa. So you have to put it back and make it shorter, for example. And these principles, I guess, so they are similar for the many approaches, I guess. So I think it's a general neurophysiological way of thinking. Yeah.
And every patient seems to have a different level of reactivity when we do reflex locomotion. What is the reason for that? Like what makes more people reactive, and other people you can do treatment for 30 minutes and feel like nothing's happening?
Well, I think the answer can be why one can think or draw the nice pictures and the other one no. Sometimes it's about inborn skills, and so this is two things. For example, you have a family, and the family are the musicians. And so apparently the child has a genes from two musicians. And more than this, when the child is exposed to the music, so he will continue in this way, so the genes plus kind of experience, and mom, I want to do the same what you are doing. Mm-hmm. And I have seen the little child, so she was like 4 years, and she was playing the violin. Yeah, so it's amazing. So, and this is together, brain, experience, surroundings, And when somebody is really reactive, it's something like a not skill which is learned by inborn, and someone is fast in it and someone not. But it's really rare that you can't see any reaction.
Right.
So it's cannot be. I think it was not be explained because simply one can draw the picture and one cannot. Sure. Yeah.
And how capable is the body to take this new information that's being given to it? So if you take somebody, a 25-year-old patient who comes to you with low back pain, mm-hmm. and we do reflex locomotion with them, and we only see them one time, mm-hmm. How plastic is the system? Like how,
Well, when you look at the papers which are describing the a brain development, so the brain development is not finishing at 6 years. So even at the age of the 30, 40, there are some processes. And we are happy. So I'm behind.
What about 46?
We got a little bit of time. Not much. I got a little bit of time.
You're not.
That's true.
But this is about the plasticity. The younger the patient is, the more plasticity. And this is a really huge and a really critical and important situation or information that when we are working with the children, this is this factor of the huge brain plasticity.
Right.
So the later, so we have no such a big plasticity. Also, the connection and the synapses are a little bit reduced to have a chance to have more these specific. When you are learning, for example, I don't know, but you are good in all these sport, right? But for example, when you will start to do the snowboarding, never ever before. So at the beginning, your brain is in a fire, all these synapses, because you want to survive, Later, after a few years, in my case, after 20 years, after a few years of practicing and training, so it's not such a fire. And when you are going downhill, you can even talk with somebody by phone.
Right.
And this is the same. So the adult person, under what kind of a treatment, the brain is not so reacting, and you have to repeat it. That's the reason why the people, they have to do something at home, because we are not so powerful when we are not repeating it so frequently. So because to create the new synapses, it means you have to repeat it and one after the other, the exercise, and then do it some period of time. Yeah. So it means that when we have a younger person, and even the person which is younger person which is in a history, good in a sport, so it's easier for them to follow our exercise. And some people, they are sitting all the time in a library because they love to study languages, whatever. Sometimes it's tricky, and they're asking, so you mean scapula, and where is that exactly? So they have no idea. And also the perception of the body.
Yeah. And I think it's an important point that 30% could theoretically still be the best in the world at their sport, but they're a little bit more susceptible to enthesopathies, orthopedic injuries.
Exactly. Yeah, but look at this. So Professor Kolář, he's also told us that javelin thrower Jan Železný, Olympic winner, he is the one from this 30%. So, and due to he was from this not ideal development, he had no such a good shape, for example, of the glenoid. and glenoid was a little bit shallower than the normal, which was the benefit for his sport.
Or range of motion.
Yeah. But because he was from the 30% of the children, so he must work a little bit more during the training, etc., you know?
Yeah.
Sometimes, yeah, definitely. So also the kids which are growing from these 30% can be, not everyone can be normal, because we also have a severe cases there.
Right.
Yeah, and it was this categorization. It was primarily done for like a central coordination disturbance for the children with cerebral palsy. Yeah.
You mentioned handling earlier. What are the big mistakes that get made? I kind of know in the United States what we see, but what are the most common mistakes we see the parents making with their kids?
Well, for what I think, it's one of those is that the child is not put in a prone position. Because the parents are afraid of the sudden death, yeah. And but nobody's talking about this. They put the child in a sleeping position in a prone, but when the child is awake, so from early childhood, so can be or spend sometimes in a prone position, because the position of the body in a gravity field, so it's creating some like challenges for the child to maintain the head in this position for a while, see something different, not only from the supine position, etc. So this is one of them. So and when you put the child in a prone position first time at the age of the 5 months, it's a big issue for the brain. It's a panic, yeah. So then the child is crying, doesn't want to be there, and has no the skills which normally supposed to have from the early weeks, before.
Premature sitting.
Also,
yeah,
premature. So we are suggesting not to help the child put in these positions in which the child cannot reach spontaneously. So when the child is not walking, so why to stand him and walk
assist,
with that? Assist. Or premature sitting, so it's a bit risky. Then the child can create the like a pediatric kyphosis. So when the child is sitting the first time, we can see some like a TL junction kyphosis, but in 10 days, it's really uprighting because it's a new skill. But when you see and the child is sitting like 2-3 months already, and it is still kyphosis is there. So it's something which is an issue a bit.
What about wearing hip degrees?
Yeah. So these devices, it's can be one extreme, the other extreme. So I cannot say it's forbidden to use it, because when you want to take the child and go buy something, and in 1 hour the child is back home, so why not? But the other extreme is when the parents are using it 24/7 almost. So I have one mother, and she had a kind of like a scarf or something like this, and she had the sun on his body 24 hours. And I said, but he also needs to be in a gravity field in this position. And she said, well, but he needs me. And I said, that's fine, that's okay, definitely. He will need you the whole life. Right. But you have to let him to realize what is this body position, how the support looks like, how the support is established. So this is also another extreme. So these devices can be used for a shorter period of time in a particular age. So when the child cannot head control, for example, so it's not good to have these devices where there's no support, where is too much hip abduction. So the adductors and the abdominal wall, it's really corresponding. And look at this, you have all the time overstretched adductors, and then the abdominal wall is really weak. Yeah, so it's also corresponding.
Could you maybe show us on what the ideal handling would be? Like, how do you...
And which age you mean?
I don't know, maybe go through a little bit of the development, I guess.
Actually, this is a topic of our courses, right?
Yeah.
So, definitely, from the beginning, so you have to be careful about the head position, also about the contact with the child, etc. And always we have to look at the axis of the body. So when we are lifting the child, it's really good to use like a rotational forces, which is helping the or activate the oblique stuff. So what I really like to have when we have a small children in this position, because you have a support for the head as well as for the trunk, and I have a control here, and the child sees all surroundings, and these are happy. And also look at this. This is a prone position.
Right.
You know? So also what you said, what is a kind of like a mistake, then the parents, they have a lot of time the child this, because
right.
I think that maybe the parents, they like it more than the child, but to have a contact, etc. But look at this, the spine is not ready for these forces so much time, and this is a kind of like a bad habit. When the child is screaming, so you are holding is in vertical position hours and hours, and then the child is screaming again because he wants to be in this position.
Right.
So that's better to say, okay, so what is happening? Da da da. Okay, everything is okay, and put it back in supine, so whatever, and to play with him or something if there's no issue like he's hungry or whatever. So and when we are actually talking about the handling and teaching the handling stuff, we also talk about the muscles which are like more and more active in some like a coordination, which is also good to know, because it's also corresponding to the age, and also the child wants to see more, and also all these planes we are checking like the area of the foot of the mouth floor. Do you use it also? Mouth floor? Yeah. And the diaphragm and the pelvic floor. Then all these planes must be parallel. This is also taught in our concept.
And then obviously try to switch sides.
Definitely. So this is also a habit that when mom is a right-handed, so all the time the child is on the left side, and then when you put the child here, it's so weird for both of them, for the mom as well. So I cannot feel comfortable, and the child is also like a oblique in a different way. But what is really good to have a thing about this, and like a prevent that you are holding him or her on one side only, definitely. So it's about the breastfeeding as well, but in breastfeeding it's another like a type of issue, because you have to like switch the side. And also, for example, for some children, they have like neck problems. So it's also apparently seen that they are happier when they are like breastfeeded from one side, and it's not really comfortable for the child from the other side. And it can be also why the mom is saying, well, when he is like on my left hand, so it's he's drinking much more than from the right. And then the question why. So if this is not problem with the soft tissue or some problem with the neck. Yeah.
What about swaddling? Is that a problem or not?
What is the swaddling?
Swaddling with the diaper and the
like a changing. Yeah, changing. Yeah. So also this is also the way how you are lifting the child. If you are lifting too much, or so definitely it's better to have a flat, like calm contact, and remove and clean what is necessary to clean. And definitely. So we are discussing. And the
blankets not
too tight.
Exactly.
Yeah, and not too like apart. But this is also kind of like a research, which is because in some countries is recommended to have like a wider position of the hips due to hips dysplasia. So it was really quite common here in Czech. But if the children, they have no hip dysplasia, it's no reason to do it.
Okay.
No.
Perfect.
Yeah.
Footwear? No footwear?
Well, no footwear. Footwear, you mean? Shoes. Okay. So this is also another issue. So I think we cannot say like a general recommendation that, for example, the bare shoes are really lovely shoes for the children, because not every child is ready to have the bare shoes. Because when you have a hypotonic children, too much laxity, or a little bit not really well developed, the bones here, so you have to support the foot for the next growing. And when the child will be in such a soft, like a barefoot shoes, so it's collapsing more and more. So when the child has a healthy foot, no problems, okay. But some of these, they have they are from these like a 30% of the not ideal development, a bit anterior pelvic tilt, a little bit soft here. Definitely they must have a kind of like a support to improve the centration of the foot, to help with to have the best position here for the next growing.
And in your opinion, when are the 3 arches of the foot completely developed? I've heard different numbers, but after how many years?
Well, actually, so we are talking about the first 3-4 years of age. So especially the longitudinal arch, but in some papers you can find even more or longer time.
Yeah.
Yeah.
Okay.
But definitely, maybe this is the last one. Definitely, the foot is just result what is happening of the rest of the body. So if you have a good position of the pelvis, good uprighting, good quality of soft tissue, there is no problem at all, and vice versa. So when I see that the child is standing in front of me and I see the plantar valgus position, so I can immediately see that the pelvis is anterior tilted and is not good proper position or proper activity of the abdominals, and you can see the scapulas, and we are in a whole global picture.
Mm-hmm. Beautiful. Well, we have to say one thing. We just decided it actually like an hour ago, but you're coming to Troy. So it's been a couple of years. Unfortunately, we've missed you. But the third weekend in February of 2024, we'll have a Pediatrics DNS Pediatrics 1 with you, Marcela, which we're so excited to have. We try to have the Pediatrics once a year. I always say, like, I really didn't fully grasp DNS until I took the DNS Pediatrics course with you. And the reason being for me is because developmental kinesiology is the backbone of it. And what better way to learn developmental kinesiology than through the pediatric lens? And so I think, Brett, you talk about it too. Like, if you understand those first year of life, then it makes so much more sense why we're choosing the positions we're choosing for our adult patients, for our athletes, for our toddlers, whatever it might be.
Oh, I think, yeah, it's critical.
Yeah. So, and then understanding too the, like we talked about, the postural reactions, and then also the reflexes and things like that. I think that just allows you to be much more confident in your assessment of pediatrics and treatment. I never thought I wanted to treat pediatrics, and now I have this sneaky pediatric practice at our office, which is just weird, but it's so much fun, and it's such a good, a great challenge too of kind of stepping out of the comfort zone of, treating normal everyday orthopedic exams, and instead being able to kind of look confidently in the parents' eyes and say, your child is developing perfectly. Like, we just need to stay the course. Like, continue doing what you're doing, and to be able to give, feedback to the parents on handling advice, like you said, or different, functional medicine advice like we talked about with them and stuff. Yes, all sorts of stuff. So I just think it's a must take if you're even remotely interested in DNS, and it's just an amazing course. So so we're really excited to have you. I guarantee we're going to have more questions that'll come up, and we'll have to do another one in February.
Well, we'll have to do scoliosis in February.
Yeah, we'll do a deeper dive.
Own one.
Yeah, we'll do a deeper dive into scoliosis in February. So that'll even be better. And so anyway, Marcela, thank you for educating us. Thank you for being such an influence to us, and for being just an amazing person. So
thank you so much, guys.
Yeah, karaoke again when you come back. Mm-hmm. Yeah, okay, just making sure. All right, guys. Come to you live from Prague. We're gonna have a bunch of these. We're gonna have a ton of people that we're gonna get on from the Prague School, and people that have been influences to you, Brett, for sure, and then me secondarily, but now becoming more primarily. So DNS is the lens that we look through every single patient with, and it is essential. So we thank you for tuning in, and good luck with patients. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.